Thanks everybody for joining the CACCN BC chapter. This is our roundtable for the fall. I'm grateful to be joining from the traditional and unceded lands of the Secwepemc people here just outside of Kamloops. Because we're joining from all across the province, I invite everybody to reflect on the lands that you're joining from today. And then Tracie Jones is here to talk a little bit about the BC Biocontainment Unit and some of the training opportunities available with that. Tracie, you want to share some information about the BC Biocontainment Unit? I'll maybe let you introduce yourself and you can take it away.
So hi everybody, I see some familiar faces on this call that I've worked and crossed paths with over the last few years. My name is Tracie Jones. I am the Manager of Clinical Operations and Program Services for the BC Biocontainment Unit, which is actually located at Surrey Hospital in the Fraser Health Authority. By background, I am an emerg and ICU nurse, and I practice mass gathering medicine on the outside when I have free time. So today I just really wanted to share with you some information about the Biocontainment Unit, which is located at Surrey Hospital, and just some opportunities for education and training that we can share. So first, I just want to acknowledge that today I am coming to you from the traditional unceded and ancestral territories of the Coast Salish people and the Nakupluk First Nations. And actually, I'm on the lands of the Musqueam today. Our team here is committed to providing culturally safe care that's accessible and respectful for all First Nations, Métis, and Inuit people across the lands which are now colonially known as British Columbia. So where have we been and where are we now? For context, we had started this unit back in 2014 in response to a large Ebola outbreak in Western Africa. The unit was mandated by the provincial health officer at that time for us to have a unit at the ready, because we really didn't know a lot about Ebola and viral hemorrhagic fevers at that time, and really didn't recognize that we in Canada are at a lower risk, but still need to have some level of readiness with the transitory nature of people traveling and the industry and that. And so at the end of 2016, when the outbreak was called closed and dealt with in Western Africa, they decided that they were going to actually stand down the unit, and all the preparation in the Ebola task force that was struck was actually closed off. And about 6 months to 8 months later, they decided, nope, maybe we should actually keep this team, because there was rumblings of other diseases and that coming to the forefront in Africa. And so we really wanted to make sure that we did have a team at the ready. So in 2018, I took over the team, and we built a leadership team with 2 physicians and 2 educators. And an exposure prevention specialist. We focused on being able to provide adult and pediatric critical care, both located at Surrey Hospital. And we started looking at different decisions of whether or not we had to actually retrofit the space that we were located in to make sure that we were meeting guidelines for containment, meaning that we needed to be almost the same level as a level 4 laboratory that would have all the big scary bioterrorism pathogens and that. And so we found out quickly that we probably didn't need that, and it was really cost prohibitive to do that type of refinement in that area. In 2019, we had subsequent outbreaks that we were monitoring at that time, and some of them were declared as public health emergencies of international concern, which means that it just mobilizes different resources within the health system globally, and different lenses and resources are attached to the containment and the response that is dedicated to boots on the ground in the zone that's affected. We became involved in a federal task force that really was looking at developing a concept of operations on what we were going to do as a national strategy. And we started connecting with teams globally to understand and level set where we were with our level of preparedness and training and our infrastructure to be able to support these types of patients. We all know, and I don't think we need to belabor 2020 to 2023 for COVID-19. We really saw our team kind of pulled apart and supported the pandemic response in multiple different ways. And our clinical space was actually dedicated to caring for COVID patients at Surrey Hospital within Fraser Health. Now, post-pandemic to present day, we're fortunate that we were able to get our team back together and really start working on how we learned from the pandemic, and then what we could envision what our program could look like moving forward, and how we would best serve the health system and make sure that our fundamental core purpose is to really ensure health worker safety when it comes to that clinical practice for somebody who has really high risk infectious disease. And so we have been really focused on trying to recruit. We've been doing large agency simulations and that. We also saw the reinstatement of the BC EHS infectious disease care team. So while prior to the pandemic, we had a very loosely formed ability to transport these types of patients throughout the province, really in 2023, we really got this team back together, and we did some comprehensive training with, and they did a large recruitment so that we would have care across the health system, or through all levels of criticality of the patient, from a primary care paramedic all the way up to a critical care paramedic, ability to transport these patients, and also infant transport team as well. We've had great collaboration with our international partners down in the US, and we are now looking at a national strategy with our teams in Ontario and Manitoba. So for context, those are the two other units within the country that could take care of patients as it currently stands right now. And we just recently did a 4-day progressive exercise in August that I'll share more about later. I'll just very briefly discuss that high threat pathogens really have to meet that triple threat. They are high morbidity and mortality, high transmissibility, and no or ineffective vaccine prophylaxis or treatment. Now, you will see, if anybody follows the news, that there is some current outbreaks that are happening right now. Particularly, there's Marburg virus in Ethiopia. There has just recently been an outbreak in the DRC for Ebola, and what these outbreaks have been able to provide us is an opportunity to institute in an emergency access way trial vaccines that are being developed right now, and with really good uptake and efficacy. So hopefully someday down the road we get worked right out of a job, and it will be a wonderful thing. But until then, we really need to look at how do we prepare our health system for these types of patients if they present. Things that are really practice related when it comes to high threat pathogens are specific infection and prevention control measures. In addition to our normal droplet contact and airborne, there really isn't a lot of existing guidance in Canada right now, other than some very high level frameworks. And then also recognizing that we probably would use the potential use of a biocontainment unit. So within the province of BC right now, we have a 3-tier system with specific roles for each type of facility. And maybe these aren't widely known yet, but we're working on trying to get this information out, and how do we socialize it, establish a governance committee, and then being able to share the education and training and preparedness across the province. So type 1 facilities are really that entry portal into the health systems. This could be your primary care provider. It could be an urgent care center. It could be a health center located in an Indigenous community. It could be your basic community hospital, or it could even be in an industrial setting on a mining site or something like that, the first aid trailer that's located there. Really, their responsibility for this is to be able to identify somebody who is ill, isolate them appropriately, and this could just even include just putting on standard procedure mask and doing hand hygiene and giving some social distancing, and then informing the right people to be able to support you. Type 2 facilities are regional facilities generally, and each health region, as you see on this table here, has a level 2 facility. And surprise if you didn't know you were on there. But the intention is that all of these facilities are still able to assess and stabilize in that identify, isolate, and inform framework, and be able to transfer patient to another facility, the level 3 site within the province. And also have some minimum lab capabilities, i.e. drawing that diagnostic blood work and sending it on to the BC CDC and onto the National Medical Microbiology Lab for further analysis for confirmatory testing. So not very different than what we did at the very beginning of COVID, where we had to send our samples out. It's a very similar process in an ERAP process. And then our type 3 provincial designated facility, again, is at Surrey Hospital, and we would provide that ongoing continuing care. Partnerships that we have currently right now, we work exclusively with our level 3 site-based operational and support teams. We have provincial connections in with other health authorities and with other teams to make sure that we are advancing the work and getting the information out there. We have our national strategy where we are working with our teams in Manitoba and Ontario currently, not only just on clinical care and processes within our health systems, but also on transport. So if a patient showed up in Alberta, how would we either get them to BC or to Manitoba, depending on, geographic location and availability of teams to transport. And then internationally, we belong to a consortium that we work with our North American partners through an organization called NETEC. And then we also belong to a high-level isolation unit committee that is chaired by Germany, and both on a quarterly basis. So lots of, I've actually been quite pleasantly surprised at the global community that we've been able to become part of. So this is our unit, one past. It's located at Surrey Hospital. It's in the critical care tower, and it is within the ICU on the 6th floor. We have specific processes and workflows that we have in order to be able to care for the patient, and activation protocols in that. For interest, this is up to and including the type of clinical care that we would be able to provide for a patient if they were admitted to our unit, and that would be ventilation, CRRT, some diagnostics. And you'll see that ECMO and cardiac arrest are actually started there. And the reason is that for a viral hemorrhagic fever patient, we wouldn't necessarily provide those services for them because of the risk of the aerosolization of blood. We know that viral hemorrhagic fevers are blood and body fluid transmitted. And so this would increase the risk and to both the provider and in the environment, and definitely probably you would not have a favorable outcome if someone is into the extremis of going into cardiac arrest. Some special considerations that we're working on right now are some decisions based on an ethical framework, family support and engagement, because we really aren't allowed to put our families in the room for these patients because of the transmissibility of the viruses. We're also looking at building in end-of-life considerations and culturally safe practices. So how do we honor patients and families' traditions, both cultural and spiritual, in a way that they can be able to say goodbye to their loved one, and but in a respectful way, but also with safety in mind. And then we also look at support after discharge, because often these patients do survive their illness. And so what is the subsequent public health follow-up afterwards? So just a couple of little slides about our training that we've been doing recently. We are, within Fraser Health, we've installed a model of a hybrid course for our emergency departments. And this is delivered through a 6-hour combined didactic and in-person training session. We partner our high-threat pathogen provider education with our chemical decontamination, because we employ the same type of PPE for both, just a different PAPR. We really focus on a hierarchy of controls. So what can we control and what is beyond our control, and how do we mitigate it? We really focus on the identify, isolate, and inform principles of practice. We highlight recommended PPE and all the different roles. We help look at department response plans, and we look at different models for screening, our PPE selection, one-way flow, cleaning and disinfection, and then any support resources. So while we do this in Fraser Health, this is it isn't adopted across all other health authorities. However, we're looking at hopefully having that endorsed, because it really is that one-stop shop for our frontline providers to be able to be certified, or to have the education for both. And recently, we were able to conduct a train the trainer session within Fraser Health with our ICU CNEs. We had 12 out of 12 sites attend and have their CNEs participate in a course where our objectives were to define our high threat pathogens, so understanding the pathophysiology and the types of pathogens that they might have to prepare for. Looking again at that hierarchy of control, and basically repeating a lot of the stuff that we would teach our frontline emergency personnel. So you're probably wondering why we would want to extend this out to the ICU, because most people come into the health system either through the emergency department or other health systems. But what we know is that patients aren't always picked up on that initial screening. We don't necessarily always identify that a patient may have a high threat pathogen in their differential diagnosis that we have to consider right at the entry point. They could be coming in so sick, or they didn't declare that they've been traveling, or they didn't think the fact that the person who they live with has been traveling and now they've had contact with them. And so there's been cases recently where this has been, serve as a really good example, where there's been transmission within the household or on a returning traveler, and it wasn't picked up, and they got through the health system, multiple different sites and facilities and units within sites without it being picked up. And so it's tracing back and doing all that contact tracing and mitigation of the risk exposed to frontline providers. So informing and arming our critical care nurses with the training and the knowledge to be able to impart that on their teams, and looking at that preparatory work that they can do is key to keeping everybody safe. Again, it's delivered over a 6-hour didactic and in-person training. And again, we're hoping endorsement by governance committee to roll out to all ICUs within the province. And then just recently, we've started doing a session called HTP 101 for IPAC, and this was delivered. We've delivered this now to 3 different IPAC groups across the Lower Mainland. It was 8 hours in person training at our training facility, and we had participants from community, from acute and regional educators as well. We really looked at 12 different objectives, but the highlights were high threat pathogen definition, the roles of all the players, fundamentally working with those principles of practice of the 3 I's, talking about workflows, and then looking at specialized SOPs. So how would IPAC practitioners support the frontline teams when they have a patient that shows up and they're like, what do we do? What's the infection control precautions we have to put into place? And how do we move safely? How do we deal with our waste? What about housekeeping? All of those pieces. So really trying to give them that foundational knowledge. And then we really gamified our session and created some group activities and simulations for them, and was received really well. So that's what we would do for our frontline facilities and our support units. But now we'll just talk about what we do for core team training. So this is what our team would look like if they were taking care of a patient within our unit. This is the PPE ensemble that we would wear. And so for our core team, to maintain our competency, it's a 4-hour orientation, and it's didactic and practical. We do a site tour as well. We talk about waste management systems that we would need for our support. Physicians get the same type of training. So our initial orientation is 4 hours, and then we do practice sessions, 3 4-hour sessions per year, and then 1 8-hour session that's a larger sim. So for our team, it's 20 hours for ongoing competency to be able to stay on the team. Again, this is a little bit about our transportation capabilities within the province. So BCEHS has an infectious disease care team. They have 2 dedicated response vehicles, and they have centrally located equipment in their PPE at one of their stations here in the Lower Mainland. This device that you see right here is called an Epi Shuttle, and this is the device that we would use to transport a patient for longer term transport. So consider Prince George to the Lower Mainland, where our paramedics would have to be in PPE for a longer duration of time. This allows them, by putting a patient in this vessel, it seals down and you actually do not have to wear PPE when you're on the outside. So this allows them to be more comfortable when they're transporting a patient over long distances. We also have the capability of not only transporting patients by ground, but also by air within the province, which is actually fairly unique. Manitoba can do this, as well as Ontario. Across the US, they do not have the same capabilities. In fact, that they have great limitations being able to transport people by air. So we're very fortunate to have both these devices and this team to support us to move patients around the province. This is their composition of their team and who would be required for a deployment. So it's actually quite big. I'll just touch briefly on an exercise that we did in August. This was, we call it Operation Critical Containment. And so really what our objectives were to try and to assess and evaluate interagency coordination and look at our operational ability of our level 3 site. So our scenario started with a 34-year-old male that came back from Nigeria with possible exposure to rodents. They were returning with symptoms of fever and general malaise, which most of these viruses are the presenting symptoms. They don't just go right into hemorrhage at the beginning of their disease. So they would present like anybody else that may have ILI or gastro type symptoms. So key thing is asking the fever and the travel questions. We did secondary screening, which included a viral hemorrhagic fever and a differential, and there was a decision made to transfer to the Provincial level 3 facility. So the tabletop exercise really was looking at how do we coordinate the decision to make to transfer the patient, and then also activating the unit. It took about 32 different teams within the province to be able to activate this unit at the end of this exercise, from the BC CDC and the Ministry of Health all the way through to the clinical team at the site. So we started out with the tabletop exercise on Friday, which then translated into a live simulation exercise and drills over a process of 3 days, where we created an environment that we did an admission, and then we did the patient decomposition, ventilation, lines and all the things. And then subsequently the patient passed, and so we were able to practice our post-mortem care and specialized processes for death processes. We were really able to evaluate the level 3 activation at the site, which was fantastic, which we haven't had an opportunity to do before, and we were able to evaluate the interagency coordination for the admission. So the outcomes for this were, we had to measure what our outcomes were. We did a debrief post-tabletop exercise. We also administered surveys and after the tabletop exercise and after each of the simulation drills, and then we did a SWOT analysis. And so these are just some of the metrics that we were able to gather. For anybody who wants to, and I can send this to Sybil afterwards, there is a video here that you can choose to look at, and it was just Fraser Health Media Communications team did a video for us and posted on social media of the simulation. So you get a picture of what we look like and the work that goes into what we do every day. And then I think I'll just finally finish off with that we have some key resources that we developed and we can share. We have a monthly newsletter that we produce that gives you some updates on what's going on with the team. We aptly named it Going Viral. It gives you some information and situational awareness about current outbreaks that are going on in globally, and just some information about our team. And we're always recruiting, so we take full scope ER and ICU nurses plus respiratory therapists. And we've actually changed our model of care to also incorporate med-surg nurses, because we recognize that the journey of the patient doesn't always require critical care scope of practice. And so that we really look at that whole journey and who are the most appropriate caregivers to be part of that. So, and then just some pamphlets that we create on, are you prepared for high threat pathogens, PPEs, recommendations, and that. So with that, I will stop there and open it up for questions. I know it was a big information dump, so I apologize.
Tracie, I had a question around the training with the health authorities. Is that done? Is that interdisciplinary training? Or like, do the nurses and physicians and RTs train together?
Yes. So for our team, yes, they all train together, and yes, we could offer that out to anybody who is interested. And for the different sites in that, yes, we could provide that education to any frontline providers that would clinical care for sure. Yeah. In fact, I actually did a talk for the resident doctors, the infectious disease doctors for UBC, and they were very interested, which was nice. It's a nice opportunity to get people at the front end of their career to really start socializing this and embedding the principles of practice of just good infection control and point of care risk assessment. So yeah.
Excellent.
Hi, Dennis.
Excellent.
Very good talk, Tracie. Thank you. I'm just curious. I work with the infant transport team with our PQ transport team here in BC Children's, and that Epi shuttle, like, really impressive. Is there one specific for pediatric population?
No, that one will do for the pediatric population. And if you know Brian Thornburn,
yes,
he's the training officer, one of the training officers for BC EHS IDCT. So I would absolutely connect in with him. He will be a great resource, and we're going to be doing some work with CW upcoming in the new year. So we will make sure that we include you.
Perfect. Thanks so much.
Yeah, you're welcome.
So this will be slowly running or coming out to all the other health authorities here, because we're up here in the north in Prince George. So we have a lot of workers from elsewhere, especially with our camps that are like in Terrace and Kitimat and Prince Rupert and everywhere, Vanderhoof area. So you guys will slowly move this biometrics to us.
So really great question. Yes, our intention is that we want to roll it out to all health authorities, and we recognize that historically Interior and Northern have been kind of left out. We really got sidelined at the beginning of the pandemic because that was our next goal was to start rolling it out further. Right now, because of the health authority reviews that we all know are happening, we're just trying to figure out where we're going to land, whether it be in PHSA or stay in Fraser, and then getting that governance structure. But yes, definitely want to come up and see you guys, particularly in the north, knowing you guys have such a huge high industry and transitory people coming in and out, the 2 weeks in, 2 weeks out kind of thing. Totally understand that. It's a huge risk. And so, yeah, absolutely. So definitely let's connect offline, and love to talk to you more about it further.
Wonderful. Thank you.
Yeah, you're welcome.
Tracie, I had one more question about the modalities that you guys are using to promote the patient and family engagement, recognizing the family can't go inside. Are there certain technologies that you're using that you're finding particularly useful?
So I think what we learned during COVID is that we were able to use iPads and FaceTime etc., or teams, like setting up a teams meet between family members. We are starting to, in the new year when we're working more with CNW, is to look at some suggestions that we can do, particularly with our pediatric patients. Recognizing that most of these patients, like if it was a pediatric patient that presented, probably the parents have already been, and so how do we deal with that? Do we keep them in the same room? Do we separate them? There's all these considerations that we have to make, and a lot of them are a point of care decision that will have to be made. But child life will be a big support for us. We're also talking to our spiritual care team and trying to really look at the resources that we can adapt to be able to support all aspects in a holistic way, our patients, and honor their traditional practices, and that our room is glass and glass doors, glass windows on it, and so we would be able to keep families on the outside because that's considered the cold zone or a safe zone. But really, we're going to have to take a case-by-case basis because we don't want to upset the patient enough that they want to try and get out. Like, we really have to look at the dynamics of that family and the visitors and that, and really limit the number of people that are going in there as well. We really need to be mindful of the fact that the more people that we introduce into an environment, the higher the risk that there's transmission, right? And so that's why we have those foundational ethical frameworks that we work with, is what is the best for the patient, but what is also the risk benefit to the healthcare worker and the general public as it stands. So some of the decisions will be made by the provincial health officer and out of the clinical team's hands. It just depends on the pathogen that presents for us.
Thanks. That was a very comprehensive answer. No, that's great. That's what I wanted to hear. It's really, I think, comforting. I find it comforting anyways to know that like all of these little details have been thought about. Like, it seems like you guys have done a fantastic job thinking about all the interdependencies as well. Like when you were talking about the multi-level and like multi-agency mobilization during the like practice event, that was fascinating to know how many different departments, including like BCCBC and like all of those things that were mobilized during that practice event. That's fantastic.
Yeah, and so it was really exciting to have all those players at the table together. Again, it was the very first time that we were able to do that and really bring together. I think probably we didn't even hit on all the people that would be required because we didn't have our federal partners from FAC there, or the federal, like Health Canada would be involved as well. There's a lot of people that, I don't know, there's a lot of interest around some of these viruses. People get a little nervous when one of these events, right? Just, you know, it raises the hair on the back of some people's necks. So for us, our team, I'm really confident in our team's ability, but I'm more confident in our health system's ability to be able to manage a patient if they were to present. And that exercise allowed us to really start having those really good conversations to understand what are the requirements and who do we need to have sitting at the table with us at that time. So if you are interested in signing up for the newsletter, just shoot me a text or an email and I will add you to our distribution list. We're not automated enough yet. I'm looking to hopefully be able to do that, so you can just click a button and sign up. But yes, just go ahead and send it to me.
I'm just going to put your email in the chat here.
Oh, thank you. And
yes, got it.
Interesting that you made a comment about nursing students. We would love to get into the nursing schools to be able to even just do like a half-hour session to give them the high threat pathogen 101. We really want to try and get people at the entry of their career, so we build those core foundational principles of practice for infection control. And by, like, for clarity, I'm not an infection control nurse, nor have I ever been, but it's something that we can mitigate so many risks to our health system and to ourselves. We don't want to take this stuff home with us, right? And so if we can protect our staff early on and give them those tools and that knowledge to be able to keep themselves safe, then I think that, you know, our job is that's our job as leaders and as practitioners that have this knowledge. I speak as a mom of a fourth-year nursing student who's going to be graduating in April, and so I want her to be as safe as possible, and make sure that we don't repeat what we did at the beginning of COVID.
So thank you everybody for tuning in to the CACCN BC Roundtable education session. If you liked what you saw here and you'd like to help support the BC chapter, please sign up for CACCN membership. We do some fantastic things all across the country and starting to coordinate these education pieces across the country so that we can learn from our colleagues from all the other provinces as well, because we're all doing some great stuff together so we can share broadly. So thank you again for attending. I hope you have a fantastic rest of your week and weekend, and happy holidays, everybody.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.